Okay, so my name is Rachel Sayre. I'm the Heart Disease and Stroke Prevention Coordinator for the South Dakota Department of Health, and I'd like to welcome you to the first of a 4-part webinar series on quality improvement. This webinar is being recorded and will be posted online to our Department of Health Quality Improvement website, which you can find listed in the bottom middle box under the Quality Improvement Resource Guide. All the registered participants will also receive a link to this recording after the live presentation as well. Throughout today's discussion, please feel free to type any questions or comments you have in the chat box at the right side of the screen. There will also be time for discussion after our speakers finish their presentation. Please note that the phone lines will be muted throughout the presentation to minimize background noise, but you can unmute yourself by pressing *6 if you have a question or comment. There are also several other links, other resources listed in the links box, which I encourage you to further explore. And you can also download a PDF of today's presentation in the handouts box located on the bottom left side of your screen. So before we dive into today's discussion, I'd like to let you know a little bit more about why this webinar series was developed. In January of 2016, about 24 healthcare professionals began developing a strategic plan for statewide cardiovascular health, and it was finalized and implemented in 2017, and the current version of the plan is what you see here. It can be found on the South Dakota Department of Health's website listed at the bottom of the page. During the process of developing the strategic plan, 4 different goal areas were identified as denoted by the different colored columns. Each of the 4 goal areas has a work group focusing on the area's designated strategies. The first thing the prevention and management group decided to concentrate on was encouraging the implementation of quality improvement processes in health systems. Before the group could figure out how to do this, they had to first establish a baseline. So a quality improvement assessment was completed via an email survey. Results indicated that there's a wide range of knowledge, staffing, and implementation of QI throughout the state. It was also evident that there's a disproportionate amount of resources available to facilities depending on location, size, affiliation with a health system, etc. So based on the survey results, the work group decided to compile a list of resources already available related to quality improvement and house them in an easily accessible place on the Department of Health website. After completing that, the work group decided to expand this resource guide into a toolkit, which will include further information related to the QI process, as well as several case studies and additional helpful materials. This webinar series has been developed to supplement the information included in the resource guide and the toolkit being developed, and to serve as a platform for professionals across the state to promote discussion around QI needs, encourage partnership between organizations, and provide an opportunity for successful QI initiatives to be showcased so that we can hopefully spark some similar projects across the state. During today's webinar, we're going to focus on the return on investment as a case for implementing quality improvement initiatives, and we will hear from Kathi Mueller on the Medicaid Health Home Incentive, as well as Dr. Preston Renshaw on a quality improvement initiative around cancer screening. There we go. So we will start with Kathi. She's the Program Manager for the Department of Social Services Division of Medical Services. She works primarily with South Dakota Medicaid care management programs such as the Health Home Program and the Primary Care Provider Program. She was part of the team of state and non-state stakeholders that helped to create the Health Home Program. She previously worked as the State Registrar for Vital Records for the Department of Health and served as the Senior Advisor for Health, Human Services, and Social Services for former Governor Rounds. Kathi, I will turn it over to you.
Thank you, Rachel, for this opportunity to speak today about a program that we have been working to implement over the past 5 years, sneaking up on 6 years. So before we begin to talk about the financial incentives that we are just about to provide for the first time, I want to share with you a little bit about this care coordination program that we have implemented across the state. So The Health Home Program is a medical home model that focuses just on Medicaid recipients who have been identified as high-cost, high-need recipients. The program was created and implemented with significant stakeholder input, and that stakeholder group remains involved and makes recommendations on policy even today, including the financial incentives that we're about to provide. This program has two main goals, and the first is to reduce the cost of care for these high-cost, high-need recipients, along with improving the health outcomes for these recipients. So I want to share with you what makes you eligible for a health home. So the first thing is that you have to be a Medicaid recipient, and you have to be covered by full Medicaid. And then this can be individuals who have Medicaid and Medicare, as well as Medicaid and waiver programs, or any types of individuals who are fully eligible for Medicaid. But you also have to then, once you're fully eligible for Medicaid, you have to meet the following criteria. You have to have 2 or more chronic conditions, and those chronic conditions are listed below, or one of those chronic conditions and at risk for another, which are also defined separately down below. Finally, with one severe mental illness or emotional disturbance, you can become eligible for this program. So we determine eligibility looking back at 15 months worth of claims data history, and it's based on diagnosis. And the Medicaid recipients that meet this criteria are stratified into 4 tiers based on the recipient's illness severity, and we use an algorithm called the Chronic Illness and Disability Payment System. So I also wanted to share with you that we have 2 types of health homes. One is a primary care model based on the designated provider being a primary care provider, a physician's assistant, or advanced practice nurse working in a federally qualified healthcare center, a rural health clinic, a clinic group practice, and Indian Health Service. As part of that, you create a healthcare team. Typically, it involves a dedicated care coordinator or health coach, other support staff. Sometimes if they're in a waiver program, it can also include a case manager. So you really take a look at the recipient and you determine, do they need other specialists like OT and PT as part of their team? It just really depends on the recipient. And we also have what we call the behavioral health model, which focuses mostly around our community mental health centers. And the designated provider there is very loosely defined a mental health provider. Again, they form that team. Usually it includes the primary care provider for that recipient, and then they take a look and work on that recipient as a whole. So one of the key components of the Health Home Program is that they're required to provide one of the 6 core services to all individuals as appropriate who are enrolled in the program. As a result of providing one core service per quarter, they get paid a retrospective per member per month. And so, for example, if an individual was in the program all 3 months for quarters January through March, then they provided a core service, they would get paid the tier level payment for that recipient for all 3 months. If they were in only 2 months because they weren't eligible for 1 month, they would get paid only 2, and so on and so forth. All medical services related to providing services for this individual are paid at your current reimbursement structure. So what is a core service? So a core service is something that the recipient should be engaged in, not simply a provider care conference. It should be something very specific to the patient, and it should be tied to their care plan. It should be documented in the electronic health record, and finally, it should be a service that has not already been paid for some other way. You cannot claim immunization or some service as a core service and then bill for it separately. So here is a list of the 6 core services. So comprehensive care management, care coordination, health promotion, comprehensive transitional care, recipient and family support services, and referrals to community and other social support services. So when we created a model of this, this is what we see. We want to keep you healthy by planning your care, supporting you and your family, and connecting you to other care. So just kind of the care is focused on the recipient, and that's kind of a depiction of what we feel like the Health Home Program offers. It's just a big circle of care surrounding the recipient. So since the inception of the Health Home Program, share savings or performance incentives have always been part of the dialogue. But we just really needed the evidence to prove that it was working, and that took us a while to get at. There is specific guidance from the Centers for Medicare and Medicaid Services about how states can share money back with providers, and I provided you a link to that in case you're interested. So there's a few ways that health homes help to avoid Medicaid costs. So specifically through care coordination. This program helps to create a relationship with an individual within the clinic who can serve as an advocate for the recipient. That individual establishes a relationship and is much more likely to exceed with motivational interviewing or other techniques that can be used to help make sure that a recipient is successful. The advocacy of that individual helps open the doors for recipients when they are unable to open them themselves. And we have also found that care coordination helps to avoid costs for payers such as us. So in both calendar years 2016 and 2017, this program helped to avoid $7.7 million, and that's in each year. $7.7 million of what would otherwise be spent on these recipients in Medicaid. And so I also wanted to share with you what health homes benefit. What is the benefit for clinics? They find that their recipients are much more engaged. The challenging recipients are getting the care they need, and usually their health improves. These recipients, we see less ER visits and avoidable hospital admissions. We have also seen better health outcomes, which allows us to give a performance award. So if you're interested in seeing what our outcomes could be, I've put a link there that kind of walks you through our cost savings, our outcome measures in detail in what we call our health home dashboard. So now on to the good stuff. For the first time this last year, the legislature, because of the money that we had cost avoided, gave us $1 million to reward health homes for their performance in the 2018 legislature. We took 50% of the money and it went to every health home by increasing their per member per month by around 16%. And that took effect for the January through March of 2018 quarter. The remaining 50%, we went to what we wanted it to go to was quality incentive payment. So we worked in concert with a subgroup of our stakeholders to develop a methodology that we could use to make a lump sum payment to clinics based on how they performed in this program. So most of it is based on outcome measures, but we also wanted to incentivize participation. So we find that many of our clinics participating in this program are very small. They're rural health clinics or FQHCs that don't have a lot of individuals in their program, but we want them to remain there because they're serving some of our most remote and rural areas. And so we took a portion of that money and we created a base payment for clinics with an average caseload of 15 or less to incentivize their participation. Then we looked at a subset of the outcome measures, really focused more on process and things that the health home could control. And we compared all of the clinics to what the statewide average was. And based on whether or not you were above the mean, we stratified you even further. So those further above the mean were given a larger payment based on their outcome measures, and those who were just above the mean or the next rung down were given a smaller, just kind of a base payment. And then we also took that payment and looked at the case mix. So individuals who were serving Tier 4 and Tier 3 and 2, so we wanted to take and reward those serving the highest number of challenging individuals, our Tier 3s and Tier 4s. And so we created a third payment method that was focused around how they did in the outcome measures and the case mix that they had. So why should you as a clinic be a health home provider? The per member per month provides coverage for items not reimbursed by Medicaid. We feel like we have happier patients because they feel like they've been heard. The team-based approach really frees up providers to take care of patients because you have that care coordinator that will be your first line of contact. And the cost avoidance created through the program helps to increase rates for both the per member per month and performance bonuses. So I'm going to also now talk about if you are not a health home, which we have a great deal of participation across the state, about 130 clinics. But we always need more, especially in some of our specific counties like Yankton County. We always need more down there. So if you want your clinic to participate, you just need to submit a completed application, and you can find that application on the website listed there. Each designated provider within your health home needs to sign an attestation and review the standards and core service definitions. And then the health homes may begin providing services only at the beginning of the quarter. And so the quarters start on April, July, October, and January 1st. But because we have to allow 35 to 40 days for individuals to make a decision about being in the program, we really need to have those applications in 40 days before the start of a new quarter. That really summarizes the program that we had and the quality incentives or financial incentives that we've provided to or will be providing to our members as soon as we get the approval from the Centers for Medicaid and Medicare Services. Are there any questions?
Thank you, Kathy. I've actually learned a lot about the Health Homes program this past year, and the more I learn, the more value I see in this program for both of our facilities and our patients. So I did have a question. You said you have about 130 clinics that are enrolled currently. I guess I really don't have any idea how many clinics we have in our state. Do you have any idea about proportionally how many are health homes versus not?
I unfortunately do not. Sorry.
Yeah, that's okay.
Because we don't license or certify clinics perform throughout the state. We enroll providers, not clinics, unless you're an FQHC or rural health clinic or Indian Health Service unit.
Okay. And then I was also wondering, do you guys actively recruit clinics, or how do people generally find out and start enrolling in the program?
So we try to identify areas where we know there's a need and try to actively enroll them. We also, because we have all of our big systems involved, we can say to them, you know what, I think you're missing a pretty substantial group of people in this area, and really encourage them to enroll those groups. So for example, Avera for the longest time didn't have Mitchell involved, where we had about 100 individuals who could be attributed to that clinic there in Mitchell. And so we really worked with them and encouraged them to try to enroll that group. And same with the regional health. They're still building their program. So they came on early with one clinic, and then they added 2 more like the next year. And now we have most of the clinics in the northern and southern hills participating in the program and within Rapids. So it's a matter of kind of trying to identify the need and approaching them in a way that makes this a value for them. So another recent add to the program is the Huron Clinic. It took me a while, but I finally got them to agree to join. And so that and Mobridge and their series of 3 clinics up there, we got them to enroll as well. So it's just a pounding the pavement type of deal. Other than I clearly do not walk between here and there. So.
Thanks, Kathy.
Yep.
Does anybody else have any questions or comments? Remember, you can type in the chat box or press *6 to unmute your phone line. And if you do come up with anything in the meantime, please feel free. We will have an opportunity to ask questions again at the end if you think of something. I do have a potential question, actually, for Kathy. So it sounds like care coordinators help create better care for patients. Are there any specific examples of how the care coordination saves costs?
So if you take a look at our dashboard, you will see some success stories, and most of that is really the care coordination. piece, having that one care coordinator that really works with that recipient to make sure they're getting everything they need. There's an example out of Rapid where they found an individual who was illiterate, and so he didn't know how to take his medication. He didn't know how to check his hemoglobin A1C. And so by working using pictures and bubble packs that had the time on them that really matched up to a digital clock that they gave him, they could get him to take his meds on time. They created meal plans with sunrises and sunsets of what he could eat, and just really working within his ability to understand how to change his diet and take care of himself and take his medication. And then they worked over and over and over with him to teach him how to manage or check his blood sugars. And through that, they were able to really improve his health significantly. And so there are several examples out there, and almost all of those are related to the care coordination of the that really is
a great example.
Yep. It's the Extra Love program.
Yes.
And we have a lot of people that need extra love.
Mm-hmm. And Sarah included the dashboard link in the chat box, so please feel free to go to that and find out about the more cost savings that those care coordinators provide. Now we're going to hear from Dr. Preston Renshaw. He is the Chief Medical Officer of Avera Health Plans and Dakotacare. He earned his medical degree at the University of Nebraska Medical Center in Omaha, a master's degree in healthcare quality and safety management from Thomas Jefferson University in Philadelphia, Pennsylvania, and a master's in healthcare administration from the University of Sioux Falls. And after practicing for 10 years, he joined the leadership of Avera Health Plans in 2014, where he has overseen disease and case management, risk adjustment, quality, provider relations, pharmacy, wellness, and medical policy. Dr. Renshaw has dedicated his career to improving the quality and health outcomes experienced by members and providers across the Avera network. And so now, Dr. Renshaw, I will turn it over to you.
It's a pleasure to be with everyone today. I was excited when the team asked if I'd present a small quality project that we had done in the past with the health plan, the health system, and some of the work from Thomas Jefferson University. I can't say enough about the Health Home Project for the state of South Dakota and the Medicaid population. We have been a part of that program as well. And the stories of the engagement with our care coordination teams and meeting members, patients where they're at, I think is extremely important. Providers have traditionally, and I would say even today, are good at complex medical decision making and treatment plan design. But I think the most unfortunate part is, as we talk about population health, is the fact that we can only control what happens in that 15-minute visit. The importance, the 85% of the time that a patient spend outside of our walls are truly what impacts their overall health, and being connected to them through a care coordination or a medical home type of model really changes that relationship to improve the overall outcomes of the people we serve. So again, kudos to the state of South Dakota and the program. I think moving forward, health systems, health plans within our state, we've tried to move our providers into these type of arrangements because quality improvement is hard. It's hard work because we're fighting fires day in, day out in our practices, and to try and kind of strategically design a quality improvement project even within a medical home is difficult if you don't have the resources. So having those care management fees that can help with providing resources to do a lot of the tracking and the data analysis behind it, or skill sets that a lot of providers, nurses, others have not really had in the past. So I think, again, that's the importance of the toolkit that the team has developed to, learn some simple, easy, quick hits and trying to improve some of the quality incentive work that you all are doing, I think is really important, because without that resources, it gets really hard. So that funding mechanism, I think, is going to be important moving forward for any practice who wants to participate in these efforts. And hats off to those clinics, particularly those small clinics, who have been a part of this, because that's not an easy lift, and so their services is greatly valuable. I think from this particular project, I wanted to show a very simple example, particularly when it applies to the care coordination teams around colorectal cancer. And so I think with any practice, it's important to know the why. Why are we doing a particular quality improvement project? It can be small, it can be big, but what is that reason and why we're doing that? And then the next thing is, I think it's important to really understand, well, what's our true performance? Whether it's in the small population that we're looking with, or it's in our larger population, like a Medicaid population in our clinic. How are we truly performing, and do we have all the data elements to understand how well we're doing? The next thing is quality is a team sport. Again, in our provider interactions on a daily basis, it's very much these one-on-one, very short hits in regards to patient interactions. Quality improvement is a team sport because you have to have all of your stakeholders involved. And so creating that team and that ownership, because you'll start a quality improvement project and no one really owns the project. And so that's why so many of the time these projects, they just don't get off the ground, because that ownership of making sure that we're accountable and moving it forward is often hard to do in small practices. So you need that ownership. Next thing is understanding your resources. Lots of folks are doing great quality work all around the country, and particularly in the state of South Dakota. So what are those resources? What are those folks doing across the state? Which has made some very simple changes to improve, whether it's managing our hypertensives or making sure our folks are getting in for their cholesterol, or something simple as people getting screened for colorectal cancer. Understand what people are doing, what are those resources, so you can leverage folks who are doing this and you don't feel like you have to do it on your own. I think that's important. And then again, back to the tools and resources on the website that you'll see, it's kind of creating this, what they call PDCA, for those of you who are new to quality. It's that plan, do, check, act, circle. So you're evaluating your performance, understanding what's working, what's not, and making changes as you move along to improve it. That monitoring process is important for one of these projects to be successful, because so often we just want to make a change right now. We don't have enough time to evaluate the performance of what we were doing to see if that change is really necessary, or are we addressing the right behavior change. So understanding that cycle, I think, is important. So colorectal cancer was a project we started a few years ago because the state of South Dakota, as well as the nation, has known the prevalence and the incidence of colorectal cancer and how that affects so many folks. So again, we were trying to create the why around why was it important to tackle this objective. We knew that there were lots of screening options out there for folks with colorectal cancer, and typically most providers go straight to colonoscopy, and we were missing opportunities for those folks who just did not find colonoscopy a feasible option, particularly for an average risk individual. And so we started looking at the data around, well, what were people's perception around pap smear and the difference in people's utilization of getting their pap smear like they should. Breast cancer, again, there's been so much promotion around people getting breast cancer screening, and so that's been much more utilized by the marketing and the other national organizations across the country. But you could see that colorectal cancer screening was not, didn't have the same importance for folks. They didn't think much of it because, again, it just wasn't as publicized as far as that awareness for our patients. And so there were a lot of options out there, and so we went and looked at all of the data and what were the recommendations out there, whether it was for the American Gastrointestinal Association, whether it was from the USPSTF, and looking at what could we do that would be easy for folks to do for that average risk population. We knew from the data from the state of South Dakota, HEDIS is the metric that all the commercial payers use in the state of South Dakota, and there was a big initiative by the American Cancer Society and the colorectal screening folks around trying to improve the rates of colorectal cancer screening. So again, there was a lot of movement at the time to try and address this issue, but you could see how the performance was not meeting standards through 2006 to 2012. So we knew there was lots of opportunity and lots of folks were engaged in this discussion. So again, looking at the state of South Dakota, we knew that only 43% of folks were compliant with screening, which is far behind all the others. And so Avera had been trying to make a strategic push to educate folks on the importance of colorectal cancer screening. In 2014, we had all over town the billboards on But Seriously and other initiatives to try and people to raise awareness around the issue. So there was a momentum that we could build off of in regards to our efforts. So we tried to utilize those resources, again, not trying to recreate the wheel, but utilizing resources that already existed. The team was important because, again, there was no way when folks do these projects to do it by themselves. So we knew that we had to have a system approach to dealing with this problem because, again, this is not just a one clinic issue. We have this issue all across of our network. And so making sure we had all of the right stakeholders involved because, again, if you didn't have all the inputs and understood all of the issues that the different teams were dealing with from the organizational dynamics or the impact that may have in other strategies, we needed to make sure that we understood those as we move forward. So again, creating that team is extremely important in a project like this. The next was education around, well, what were our options? And we felt that there were a lot of screening opportunities for folks with colorectal screening that we weren't taking advantage of. So we went out to the literature and we were looking at FIT. FIT had been around for a few years, and we started looking at the fecal immunochemical tests in regards to what other folks were doing across the country with FIT testing. And then we found friends at Kaiser. Kaiser Permanente have been doing FIT campaigns for years across the huge network that Kaiser represents. And so what they found was if we were getting people screened for colorectal cancer at average risk with FIT testing, we not only improved, number one, our screening rates, but we also got the right people in for colonoscopy who wouldn't ever have done so previously. So they were actually, one of the concerns when Kaiser started doing this and even our own health system started doing this was saying, well, if I'm screening everybody with FIT, people won't get a colonoscopy. The opposite actually occurred. It meant we were getting more of the right people in for colonoscopies, and we were finding higher yield on the colonoscopies that we were doing versus just someone having a normal that could have been screened through a FIT. So not only did the volume of colonoscopies for providers improved, you actually found the right people who were needed getting this colonoscopy sooner because their FIT tests actually got them in to get the colonoscopy they weren't having previously. So again, using what other folks in the markets were doing to try and understand how they were dealing with this problem. There's been lots of literature from the American Cancer Society as well as others across the nation around flu shots and FIT. FIT testing is a once-a-year test from a screening perspective. Well, there's been a huge push, particularly within our provider networks and our HEDIS around flu shots. So could we use the flu FIT campaigns that were out across the country and do some modeling around that, meaning at the time people were always coming in once a year for their flu shots, could we target those same folks who had not had previous colorectal cancer screening to get the FIT test? And so again, we knew the compliance across the state in regards to flu shots. We knew the compliance in some of our groups in regards to them getting their flu shots. So could we combine that and do what some of the other folks had done to make this successful? So this was one of the publications that came out in regards to the flu fit campaigns. This was actually a national campaign. We did not recreate the wheel on this. We were utilizing resources from the national providers on this to help develop our campaign. So again, didn't have to get real creative, just using what people were being successful with. So we knew in 2014 when we started this, we only had about a 43% overall colorectal cancer screening rate. We did not collect any baseline flu shot information on the same population. We didn't combine the data points, but again, already knew the success of our flu shots. And so we looked at the total eligible number who were able to be screened, and then we looked at the total number of colonoscopies we performed, and we figured out that on average, with this total eligible number, we were spending about $800 per case with some of our colonoscopy efforts. The additional charges that were associated with colonoscopy, whether folks were using some anesthesia or not, or some people getting biopsies, we found out the average total charge when you put that all together was about $1,400. So that included your surgeon, your biopsies, your whatever. That was about $1,400. But we also knew from 2014, from the number of new cases that were present in this population, that a new cancer diagnosis, the cost per patient was running about $32,000. So again, we were building our case in regards to how we felt we could change not only the improvements in screening rates, but over the overall total cost of care that our patients were being put through. In our pilot, we decided again to pick a small group to start with so we could see what the impact was. We started working with our commercial groups because we were already going out with groups to do flu shots. And so we found 5 groups who were engaged in our flu shot campaigns. And so those were the groups that we targeted. Again, back to the stakeholders, making sure their HR groups who we were working with understand the importance of this. And so we had lots of meetings with these groups and their teams to make sure that they were on board with this effort, to make sure that they didn't have any questions when we were coming out to the group and meeting with their employers, or their employees, excuse me. Those 5 groups, there were a total of 220 employees. Again, these were small groups who had received a flu shot, while 78 members had received the flu kit, the fit kit. So again, we were able to give flu shots to 98% of the folks when we would go out to the companies. But of these folks that we've found who were eligible, because we knew this from their population data, we were able to identify 100% of those folks and get them the test. So of those 78, 48 of those folks actually were compliant. So we were able to push our HEDIS, which was running in the 40s, in this population up into the 60s by identifying these folks in a different way. I think importantly, there was 85% of the individuals who were identified in this population had never had screening done before. So again, these were folks who were in practice had a relationship with a provider, but had never been screened. They didn't turn eligible all of a sudden that year. These folks were 2-3 years out from their original screen start date of 50. And so we found 85% of folks who just didn't have it ever before. And so again, in this small subset, we improved 19% over that 43% average. That's why I identified these folks and got them engaged in the program. The costs associated with our fit kits are very minimal. So a fit kit, you have about 87 cents for this package mailer that we would use for sending back the results. Actually, our postage costs were higher than the mailers, and then we spend about $6 per kit for this. So the cost to do a fit kit for screening are extremely inexpensive when you look at this. What we did is we built our lab who was running these for us. We build all those costs were billed back to the plan, and we would just pay them directly. So again, our clinics would have them available to hand out to folks, and then they would just mail it in, and then once we knew that this person had had it done, we'd reimburse that money back to the clinics. So we had a total of 200 kits during this process that cost us roughly $2,000. So the cost to do this was very cheap, again, compared to one colonoscopy or the cost of a colorectal cancer case. The number of kits required was about 85, and again, so a cost of $855. The fees of the, we talked about this, the fees were billed separately back from the facility, and then our tertiary lab basically got $23 back to do the whole processing as we went through this. Our costs associated with the 48 kits that returned were about $1,100. We had a total of 7 kits that had to be sent back to members because they forgot to label them. They didn't label the specimen, so it wasn't any good. We took all of those folks who had had specimens sent in. We worked with them to get a new specimen sent back so that we could get that data and get their screening results to them. And so we had about a 9% loss in our total inventory as we went along. So our combined upfront cost for the test and processing fees, again, was about a $2,000 expense to the plan. We actually had 3 members who, again, who had never been screened before, who came back with positive FIT test results. Every one of those folks, because they had the results, went in for their screening colonoscopy. So again, these were people who may not have gone for colonoscopy, but actually, because of the results, got back in to get a colonoscopy. So that was very important as far as our overall compliance. The costs associated with those 3 colonoscopies, again, were very minimal. It cost us $5,000 to screen these folks. And again, adding the screening and the diagnostic costs together, that resulted in about a cost of $7,000 for these 78 participants. So our FIT plus our colonoscopy costs cost us about $7,000. So again, minimal impact in the overall savings of this program. I think the biggest piece, and we've talked about this with health plans across the country, is one of the concerns about people doing FIT is that if I get a positive FIT test, if I go in now for colonoscopy, it turns into a diagnostic charge. So people won't go and get the colonoscopy because now they're going to have out-of-pocket costs, whether it's their coinsurance deductibles that they have to meet. We went after this process saying we don't want to inhibit colorectal cancer screening, particularly if someone has a positive result. So anybody who has a positive FIT, when they go back in for that diagnostic from one of our screening efforts through FIT, that colonoscopy and those associated costs are actually covered at 100%. We kept that in our screening benefit. So the ACA requires the health plans who sell on the ACA cover this screening benefit at 100%. We did not want to take that away just because they had a positive FIT. So that was extremely important, and that's a big win for members or patients because, again, they're not going to do it if there's additional cost burden. From a savings impact, I think the things to take into account, the savings of 2 preventable colorectal cancer cases that would have resulted in about a $64,000 cost if we hadn't identified them early. So of those 3, there were 2 with new diagnosis of colon cancer in early stage. We were able to pick these people up early versus a later stage. So when you look at that total cost of care for a initial onset of stage 3, stage 4 colorectal cancer, we actually were able to show some cost savings by not finding them at a more advanced stage when they have problems. If we had scheduled colonoscopies for each one of these 48 people who had done this, the cost of the plan would have been $67,000. Again, using that overall average cost of $1,400 a case. So then when you look at, if you take all 40 of those folks and you do FIT and you do it every year for the next 10 years, your actual projected screening costs are only $35,000. So this looks at an increase, and we added in an increased spend, so medical expense trend every year. We took a very conservative number. healthcare costs are going at about 6 to 7% bump every year. We actually chose 8 per year over the next 10 years to try and say there's more of an impact here than we originally thought. We continue to do this program today, and we still are tweaking. So back to that PDCA process, we found that we were going out and meeting with groups. We were labeling the specimens for a lot of patients. So back to the great example by Kathi. Well, you have someone who's illiterate. We were actually labeling and doing all of the heavy lifting first. So all they had to do was collect a specimen and send it. They didn't have to do a lot of the other pieces around it. Number 2 is constant follow-up. And again, a beauty of the care coordination teams or teams that can help support do this work. If we're not constantly following up with folks, they get lost. And so having people who are a part of this journey with them, walking hand in hand with our patients and saying, hey, we know you got this. Are you having trouble? Is there something you don't understand? Can we help you and bring you along in the process? Those folks were key to doing this. The other key was this is a working population. So trying to do this type of work from 9 to 5 doesn't work. These folks they're working at their business. So we had to find another way to connect with folks after hours to get a hold of them because, again, they weren't answering the phone during the work day. So that was a very important learning for us as well. Here's some of our screening materials. Again, so our marketing team was very important with us in creating information that we could use to get out to our folks. We had a nice flow sheet. This is very simple. Again, back to small, simple quality tools to kind of keep track of this so we could know who got this, what was the date, when was our contact, when was our next contact, and again, the follow-up was extremely important. But again, just a simple Excel spreadsheet to help do this work. We had workflows, again, so back to who was responsible for what, so we could have accountability to make sure pieces of the quality improvement process were handled appropriately. So again, we made sure everybody understand who was on first and who was on second as far as our workflows went. And so, again, I think I've been understanding that cycle, looking about what's working, what's not working to work on your program, I think is extremely important. But like I said, quality improvement's a team sport, and we need everybody in the practice to be engaged in these efforts. So they're very hard to be successful. Questions for me on this project or quality improvement in general?
Thank you. That sounds like a very interesting project. Even though my work focuses on cardiovascular health, I can see that there are a lot of universal practices that we can apply to pretty much any disease state. So that was a great example. Just a reminder for folks, you can use the chat box or unmute your phone line using *6. And so we would like to offer that chance for you to ask questions to Dr. Renshaw. Okay, so we've covered some really great information today, but before we wrap things up, I'd like to briefly mention that there will be 3 more webinars focusing on quality improvement coming up in the next few months, and I'd appreciate if you can plan on joining us for those as well. You can find this information on the Quality Improvement Resource site toward the bottom of the page. Registration is listed there for next month's webinar, and each of the recordings will be posted to that site soon after the presentation. So the final 2 webinars do not have registration information posted yet, so please just check back as we near the next couple months for that registration information. As you can see, our next webinar is scheduled for March 19th. During that time, we'll discuss the basics of quality improvement, what it is, and how it's used. And we'll also discuss how quality improvement ties in with population health. The webinar will be presented by Holly Ahrens from the Quinn and also Patty Brooks with Avera Health Plans. The following webinar, which will be held in April, will allow us to hear from our practitioners in the field as we present some case studies on quality improvement within the rural settings and take a special look at examining the successes and challenges for that setting. The last webinar, which will be held in May, will showcase the new South Dakota Quality Improvement Toolkit created in partnership with our Cardiovascular Collaborative. And the webinar will demonstrate how to use it and hopefully make it easier for you to access some helpful South Dakota-specific resources related to quality improvement. In closing, I'd just like to thank everybody for joining us on this webinar. I appreciate your interest in quality improvement and thank you for all the work that you're doing to help keep our South Dakota residents healthy. If you'd like to find out more about the QI resources we discussed today, if you're interested in joining the Cardiovascular Collaborative, or if you'd like to hear more about some potential opportunities to partner on QI initiatives, please feel free to contact me using the information listed here. Again, thank you, and I hope to see you back for the rest of the webinar series. And we do have just a couple minutes. If there are any further questions, please speak now or forever hold your peace. Otherwise, please fill out the webinar evaluation after we're finished here. We really appreciate the feedback. Thank you so much.